So, um, good evening. Hello, my name is Benedict Wilmes, and I'm sitting now in Bremen in the north of Germany because I had a celebration, birthday celebration here. Usually I'm in Düsseldorf in the west part of Germany. So actually, as mentioned, I'm now here up in Bremen in a hotel. And yes, nice to meet you this evening, and I'd like to speak about palatal implants and how we can use them for distalization. So again, usually Düsseldorf is right here. Um, if you're ever around, please visit us in Düsseldorf. It's a very nice city. You see some old nice buildings here. But we also have a modern part. This is a harbor area in Düsseldorf. And again, we have a big airport. You can visit us for 1 day, 2 days, 1 week. We have guests from all over the world. So send me an email and you're very welcomed to visit us here. So, first of all, if we want to speak about molar distalization, we have to speak about proper indications. So, of course, we don't distalize in every class 2 case. We have to check if there are wisdom teeth in place. So maybe it's not better to distalize, but to extract a bicuspid. So this is, of course, very important. You will see many distalization cases in my webinar today. But I don't want to speak about in which cases we want to distalize today. I just want to speak about the possible mechanics. So I'm just telling you that in 2, 3 slides. First of all, we have to make a good diagnosis and see if this is a good case for distalization or not. So how can we distalize in the upper arch to get some space for the front teeth? Of course, we all learned to start and to work with a headgear, but we need a lot of patient compliance. And we have more and more adult patients. And of course, adult patients, they don't want to wear the headgear. So I think headgear is not so popular anymore. There are some non-compliance, just intraoral molar distalization devices, and for instance, the distal jet, keyless slider, or pendulum. Yes, they're non-compliant, so they're working without much compliance from the patient. However, these appliances are more or less tooth-borne. That means we always have a big anchorage loss. That means maybe you're distalizing your teeth 4 millimeters, but so this may be 4, but around about half is anchorage loss. So the crowding gets more severe, it's round tripping. So this is a big disadvantage of these intro appliances that are just tooth-borne. This is a nice overview how big the anchorage loss is, and it's in some studies more than 50%. Okay, so this is the disadvantage. Second disadvantage of dental anchorage is in young patients where we still have mixed dentition. So again, we are maybe distalizing the molars 4 millimeters, but the anchorage teeth will move forward. And again, if you are still a mixed dentition, we have a high risk that the canine is pushed medially as well, and there will be resorption in the area of the lateral incisor. So this is a patient of mine, and you see that there is a risk of root damage right here. Okay, we have been successful with distalization, but these teeth migrated medially, and so there's a big risk. And the third disadvantage, that after molar distalization, you need a second appliance for molar anchorage, because we want to keep the molars now in the distalized position. So we need two appliances. One appliance is for distalization, and the second appliance is for molar anchorage after distalization. Okay, so if we have a look at the conventional pendulum appliance, we have three big disadvantages, and this is the reason why maybe mini implants or TADs can help us to avoid these disadvantages. And this is what I want to talk about during the next 1 hour 45 minutes. So, where to insert the mini implant? And this is a little bit how we started. We started 20 years ago with screws that were inserted between the roots. We call them interradicular mini implants or buccal mini implants. This is, for instance, a screw between 3 and 4, and there was not enough space for the second bicuspid 5. So in this case, we did some derotation, a little bit distalization with this kind of mechanics. However, there's a couple of disadvantages if you use mini implants between the roots. We will speak about this later. So to be honest, we don't do this anymore in our university. We moved totally to the anterior palate. Why? In this area, we find the best conditions for mini implants. There is no risk of root damage. The bone has a high quality. Soft tissue is very thin, and so we can do many things with mini implants in this area. Second disadvantage of buccal mini implants, if you put them in between the roots, you cannot move the teeth anymore. Okay, maybe 1 millimeter, and then movement of the teeth is stopped by the mini implants. Okay, so this is true not just for mesialization, but also for distalization, as you can see right here. And from my point of view, this is maybe the biggest disadvantage. Certainly, there's sometimes not enough space between the roots, so I'm afraid to squeeze a mini implant in between 6 and 7 in this situation, because it will damage the root. But even in this area, it seems very tight, so it's not so much space for a mini implant. Where else can we insert them? This is what we also have tried 20 years ago. We inserted them in the tuberosity, but in the tuberosity, the bone is not dense, and secondly, the soft tissue is very thick. And these two disadvantages result in a high failure rate of mini implants in the tuberosity. Okay, so this is a tuberosity area. So sometimes you still see lecturers, doctors are happy and successful with these screws, but the failure rate is too high. Maybe it works in some cases, but not on a daily basis. So this is, for instance, this mini implant. We tried to use it for molar anchorage, and this happened after, I think, 3 or 4 weeks. It moved just like that through the bone. So thick, soft tissue, low bone quality. This is a high risk for failure. So my take-home message for you: don't insert screws in the tuberosity area. I have a good friend, Björn Ludwig, and his group published this paper. They compared mini implants in the palatal area to mini implants inserted buccally. And you see there's a big difference if it comes to the success rate. Okay, so in the palate, in the anterior palate, almost 100%, buccally 71. Okay, so big difference between these two areas. Take home message: go to the anterior palate. Yeah, it's my favorite. It's our favorite area. We can do many things using this area. Today I'm speaking about distalization, but you can also use it for mesialization, um, molar anchorage expansion, incisor protrusion, class 3 traction. So molar intrusion in open bite cases, it's a super area. I love it. And you will see we can use it for distalization for many different appliances. So in total, in Düsseldorf at our university, we have inserted up to now around about 4,500 mini implants, so quite many. And the success rate is not as high as in Björn Ludwig's paper, but it's very high. So 1 out of 20 is a failure. So we still have failures. We have to be honest, of course, but failure rate is very low. Maybe if you start with palatal screws, failure rate may be higher, but this is normal. We have a learning curve. Yeah. So how to connect mini implants in the palate with our mechanics, with our appliances. And for this purpose, it's useful to apply mini implants with abutments. Okay, so if you are using just one mini implant, we are using these kind of devices. These are abutments. Abutments means you can fix them on top of mini implants to have a stable connection. And there are abutments with wires, there are abutments with a bracket in place, etc. In many cases, we are using two mini implants. Why? Of course, two are more stable, and the risk of mini implants is always that they tip. But if you use two and couple them rigidly, the risk of tipping is very low, much lower, especially if you couple them in the line of force. Okay, how to couple two mini implants? We are using these kind of plates, and this makes it quite easy. And if you use these plates with wires in place, the risk of tipping is very low, and there's not much laboratory work. So many appliances you can bend and adapt without an impression. Yeah. So this is one of our first papers where we showed some mechanics about the anterior palatal, distalization, molar anchorage. We speak about this today, molar anchorage, mesialization with direct and indirect anchorage, rapid maxillary expansion. This is now a very hot topic. Maybe you know Dr. Von Moon from LA is using this appliance. He's calling this MAPE with 4 mini screws, or you can even use it for alignment of impacted teeth. So we started a little bit with the palate, and now there are many companies, many doctors using this area for many anchorage purposes in the palate. So there are quite a few mini implants with abutments nowadays available. So topic is now today distalization. How can we now design the mechanics for distalization? And one idea is to do indirect anchorage. What means indirect anchorage? Indirect anchorage means we are coupling mini screw with, for instance, bicuspids, in this case, the first bicuspids. And the goal is, if you are now using an open spring for distalization, in this case on both sides, and the mini screw is preventing that the bicuspids are moving mesially. This is called indirect anchorage. So indirect anchorage always means you are coupling your mini screw with teeth that they don't move. Yeah. So in this case, the patient asked for non-extraction, which is from my point of view a little bit stupid. It is, to be honest, not my case. It is treated by a friend of mine. So they wanted to treat this patient without extraction. It is like it is. Patient asked for it. I think it doesn't make so much sense, to be honest, but this is how it worked out at the end. It's just to show you how indirect anchorage usually is designed. So this is how, again, indirect anchorage looks like. The mini implant or 2 mini implants are coupled with the bicuspids. You have 2 open springs and distalize the molars. And after molar distalization, you need in many cases a second appliance for molar anchorage and for retraction of the anterior teeth. To be honest, I don't like this two-phase treatment too much. Maybe it's smarter to use direct anchorage and the one-phase scenario. So what does direct anchorage mean? Direct anchorage means the forces are applied to the molars directly, the teeth that you directly want to move. Yeah? And we see some advantages of direct anchorage over indirect anchorage. What are the advantages? Advantage number one, it's faster. Why is it faster? When you distalize the molars, the bicuspids are following due to interdental fibers. Yeah? On the left side, the bicuspids cannot follow because they are connected to the mini implant. Okay, on this side they will follow and they can follow. Second advantage of direct anchorage, the appliance that was used for distalization can afterwards used for molar anchorage. So you don't need the second appliance. Yeah, using indirect anchorage on the left side, you had mostly two appliances, one for bicuspid anchorage and the second for molar anchorage. In this case, you only need one appliance. And certainly there are no brackets needed. And this is, of course, very popular, especially in adult patients. Um, and we can finish the case with aligners. I think this is a very, very smart combination. And I personally think this is the future for our orthodontic profession. I personally love aligners. They're getting better and better. But bodily movement is very difficult. If you try to bodily distalize or mesialize molars, you can be successful, but in many cases the teeth will just tip. So I think the combination with these sliders and aligners is very promising. So do we use one mini implant or two mini implants? Actually, we have many patients where we use just one because in adults the bone is very dense, and in adults you mostly need just one. In children and adolescents the bone quality is not so high, so in these cases we always use two. But we learned this over the last maybe 15 years, and I like to show you where we can insert. Yeah. The best area is very easy to identify, and this is one of my favorite slides. It is a so-called T-zone, and this T-zone. This T-zone is very easy to find. It is distally or posterior from the rugae in the area of the bicuspids, mostly in the area of the second bicuspid. But this depends a little bit on migration of the teeth. Sometimes they move mesially. So my recommendation is to look more for the rugae and not so much for the teeth, for the dentition, because dentition might have moved mesially before. So we don't need a cone beam CT. We don't even need a cephalogram. All we need to find this position is to look at the rugae. Many patients, there are 1, 2, 3 rugae, and we stay posterior in this T-zone. And if you go in the molar area, we have to stay in the middle. Yeah. I'm here, sorry. So in the molar area 6 or 7, you can insert them also, but we have to stay median. In the area of the bicuspids, we can also insert palm median. Very important take-home message. And we started maybe 15 years ago with more or less median mini implants. There's a small tendency in our department that we nowadays we have a tendency to use more paramedian mini implants. Yeah. So this is what we learned. We are planning now a study checking if paramedian or median are better. Clinically, it looks like that paramedian mini implants have a little bit higher stability. Yeah, but the mechanics look very similar. So some doctors they like to stay in the median, some doctors like to stay paramedian. It doesn't matter so much. Yeah, again, in our department, our hands, we moved a little bit to the paramedian ear. And if you want to start with palatal tats, maybe it's better to start directly in the paramedian area. But at the end, we are using this kind of plate, mm, and the distalization appliance can be fitted similar. But we did some research on the stability. Again, the difference is not so big. It's very small. You see, we measured stability over a healing period of 6 weeks. You see, paramedian are blue. Stability is a little bit higher. Interestingly, it was higher median before. Why is that? Maybe the reason is because in the middle there are two sutures, or there are two cortical shells touching each other, and so median the bone density is very high in adolescence. Yeah, in kids, in very young kids, it's not the situation, but if they are adolescents, um, the median insertion site shows a very dense, maybe two bonds, two uh, dense bone situation. So take home message, I think we now should stay only paramedian. This is what we learned. Yeah. This was published just last month in the September issue of the AJO. And we measured the bone height, and you see again, paramedian, this is paramedian. There's a little bit more bone compared to median. So the bigger the circle is, the higher the bone um, volume is. So take out our message of this. Stay in this T zone, since it still looks like a T. Yeah, but maybe paramedian is a little better compared to median. Yeah. So angulation of the mini implants has a little bit different if you compare paramedian to median insertion. If you insert them paramedian, the mini implants should be perpendicular to the occlusal plane. If you insert them median, you can insert them perpendicular to the bone, yeah, to get more a longer bone availability. Yeah, so if you want to start in the next days with mini screws again, maybe it's better to start paramedian, but take home message, don't insert them with an angulation like this, because then maybe you might touch the roots. Yeah, so this is the only risk. So insertion should be perpendicular to the occlusal plane. How to insert? I think it's quite easy. You can do it with these manual devices. We count from 10 to 0. It doesn't take more than 10 seconds. My recommendation is not to stop, even if the patient says, I feel a little bit pressure. My recommendation, don't stop, because then the situation might get stressful. Um, uh, you can do it manually, or even better is to use these automatic drivers, the electric drivers. They are very familiar in prosthodontics, because implantologists, they use them to fix the crown with a special insertion moment. So you can maximize the insertion torque if you want to. And the maximum insertion torque for 2mm mini screws is 40 Newton centimeters. So these electrical drivers are super. I love them. Yeah, to just push the button, count from 10 to 0, and then you're done. So after insertion, you can take an impression or do a scan. So this is the procedure if you want to take an impression. We are using silicon. We have impression caps and looks like this. And these are the impression caps in the impression material, in the silicon. Now we have laboratory analogs. They represent the mini implant on the plaster model. So after making this plaster model, the situation looks like this. We have bands in place, and it depends on if you want to use bands. We have alternatives if you are not using bands, but these are the laboratory analogs. Okay, so bands and laboratory analogs which represent the mini screws. Then we are attaching lingual sheaths. These are the tubes that are stuck into the sheaths. This is a video where you can see the procedure. Pre-drilling, we don't do it anymore. We have done it if you are inserting median, but again, my recommendation, stay par median, and then we don't need pre-drilling. Yeah. So you can take an impression again or bend everything chair side directly in the mouth. So it is possible. So you don't have to use the laboratory. Yeah. Disadvantage, of course, it takes some time. Yeah. If you're good in bending, the whole procedure takes maybe 20 minutes. If you're not so good in bending, it might take longer. Yeah. But all parts are prefabricated, so you don't need a laboratory. So after bending, you can fix a bend slider for distalization with these small fixing screws. By the way, this video is also available on YouTube. This is a short version for just 1 minute. The full version of 12 minutes is available on YouTube. Just look for Slider. Okay, so funny video. You see a colleague inserting the mini screw in the pallet by herself. This was during a meeting. And again, funny story. You see, yeah, after anesthesia, she is inserting the mini screw in her palate by herself. So just to show everybody, that's not a big thing. So the palate is a very, very easy insertion site. Yeah. So don't be afraid. No roots, no vessels. Um, so this mini implant is still in place. This was 5 years ago. Yeah, so I like to encourage you to use the palate. It's a super area. Yeah, even if you maybe penetrate the nasal cavity, nothing can happen clinically. Yeah, there's maybe a little bit nose itching, but there is no big risk for anything. Very important is how to communicate with your parents and patients because they might be afraid. Avoid the words implant or bone screw because again, as kids, mothers may be afraid. So this is what we think about mini screws for distalization, expansion, etc. But if you speak about screws in the upper jaw, implants, maybe patients are afraid, and this is what they might think. So very important. Don't use these words. I use anchorage pin or titanium pin. Uh, Oral hygiene is very important. So I mentioned we have many cases. We saw many successful cases, but we also have sometimes problems. And this is mostly in patients that don't clean the mini implants. And it looks like this with a small infection. If the mini implant is still stable, you can fix this problem by using chlorhexidine jelly. If the mini screw is loose, we have to remove it. Okay, so nowadays I'm recommending this chlorhexidine jelly to every patient. Yeah, so even if they don't have infection of around the mini screws, I'm recommending to use them from day one. So let's see now some cases. I think buckle braces are still mostly used worldwide, and so I like to start with buckle brace, and I like to start with this young girl, young patient, and in this young patient, I like to show you why we nowadays use mostly two mini screws. This patient was treated maybe I think 17 years ago, and we started with just one mini implant. Yeah? We need some space in this patient for the canines. Distalization is maybe needed around 2 or 3 millimeters. Not a difficult case. Yeah. So this is after insertion of the band slider. We are using abutment with wire, and this is what happened in the next months. You see, especially in the first quadrant, a nice distalization, but we also see a small impingement. Yeah, so please have a look in this area. You see the wire drifted a little bit mesially, and this usually happens if the mini implants are tipping. Yeah? And we have distalized, so we have been successful, but as you see again before and after, but the spin slider was not super stable. Yeah? This again is the reason why we nowadays are using two mini screws. So I like to show you the follow-ups. This is now after I think 2 more months. Canines were now erupting. See a small impingement, not a big thing. You still can remove this wire very easily. That's what we did afterwards. A nice bodily movement. Of course, you might say, how about the wisdom teeth? They're still in place. Do we have to remove them before? No, I don't care so much about them. Yeah. Again, I talked about this at the beginning. If there are wisdom teeth in place, I personally would more extract bicuspids, but these parents really pushed me to do a non-extraction treatment. So this is the mini implant we have inserted. Again, we just used one. This is the situation after removal of the mini implant. Sorry, this is removal of after the brackets. Mini implant is still in place. You see a nice bodily movement. Again, wisdom teeth are still in place, and we have to make a decision later if we have to take them out or not. Probably they have to be extracted. This is a patient 3 years in retention. You see very nice occlusion. Another patient. This patient we need some more distalization. He was 16 or 17. Distalization that is needed around about maybe 5 or 6 millimeters. Of course, again, we recommended extraction of the first bicuspids, but the mother insisted not to take out bicuspids. Yeah? Patient was treated 12 years ago, so we still used median mini implants. Again, nowadays I probably would insert the mini implants paramedian. So maybe probably right here. So this is the bend slider in place. Many cases we are using small resin stops that makes the appliance a little bit more comfortable. So this is now after 8 months, and you see, sorry, all teeth on uh, all bicuspids and even the canines are drifting distally due to interdental fibers. So please have a look even at the canines. And this is a nice thing about these devices. Uh, you don't have to do much afterwards. And secondly, the appliance is almost invisible during this treatment. So please don't put brackets on the teeth during this phase of the treatment. What else do we see? As soon as we have distalized enough, we are removing the active springs. So the Bennett slider is now transformed from a active distalization device into a passive molar anchorage device. Why? We want to keep the molars in this now perfect position, and so don't remove the appliance, leave it in place, just remove the active springs. This takes 30 seconds, yeah, to remove them. Again, from my point of view, very nice case where you can see very impressive the drifting of the bicuspids and even the canines. So now again, it's a easy case. Put brackets on the teeth, level for maybe around about 3 months. As soon as you have a rigid wire in place, you can retract all teeth simultaneously, as you can see right here. Yeah. So put an elastic chain from 6 to 6 and retract all teeth simultaneously. We can do that because we have a good anchorage in place. This is a patient at the end of the treatment, very nice class 1 occlusion. Again, we didn't need class 2 elastics, we didn't need a Herbst appliance, etc. Yeah? And this is the big advantage of this kind of mechanics. Again, this was the situation before, so quite a lot of distalization. Most of the cases we don't need so much distalization. This is a patient 1 year in retention, and you might estimate where the mini implants have been before. Yeah, but mostly you don't see much. Another patient, in this case with an asymmetric situation. So we needed distalization, especially in the first quadrant. She has quite a big overjet. Yeah. And we need in the first quadrant round about 7 mm of distalization. In the second quadrant, just 2 or 3 mm of distalization. So this is the Bennett slider in place. We started with bilateral distalization. You see molars are moving distally. You see spaces now between 5 and 6. And now again, we needed in the second quadrant only 2 mm of distalization, so I removed the spring in the second quadrant. So again, the appliance is modified now from an active distalization device into a passive molar anchorage device. On the other side, we still needed more distalization, so I left the open spring for some more distalization. You see nice Borderline distalization. Wisdom teeth are still in place. Again, I don't care too much at this stage. Yeah. Now we have enough distalization, so we can put brackets on the teeth and again retract all teeth simultaneously. So this is an elastic chain from 6 to 6. Keep it easy, yeah. As soon as you have a rigid stainless steel wire in place, retract all teeth simultaneously. This is after retraction. Molars stay in place because you have a nice anchorage device in place, and you see the spring was removed at this stage. Again, if you have enough distalization, remove the spring, and now we have a passive molar anchorage device. Molars are now on the same level. As soon as the spaces are close to the distal, we can remove the slider, because for the last finishing steps, we don't need the slider anymore. And the patient is happy if you remove it, of course. Yeah. So this is a patient at the end of a treatment. You see a nice symmetry, nice borderly distalization. And here you see again before and after. In the second quadrant, we needed maybe just 2 millimeters of distalization. In the first quadrant, we needed around about 6 millimeters of distalization to correct the severe midline shift and severe protrusion of the incisors. And the radiograph lateral cephalogram before and after. So you saw a combination with buccal braces. Again, first distalize. As soon as you have enough distalization, put brackets on the teeth, level. As soon as you have a rigid wire in place, retract all teeth. What is the situation if you use lingual braces? If we are using lingual braces, we have to put the brackets from day one. Why? If you first start with distalization, your indirect bonding tray is not fitting anymore. Yeah? Of course, you can distalize, take an impression, and then fix the brackets, but there's a risk that in the meantime, teeth are moving a little bit and the bonding tray is not fitting anymore. So my recommendation, put brackets before you start with the treatment. Yeah. In this paper, you find the steps. So one patient of mine, protrusion of upper incisors, class 2, so he needed some distalization in the upper arch. You see at the beginning, after around about 6 months, after 10 months, now you see big spaces. Yeah, the molars are now in the perfect class 1 occlusion. We have a rigid stainless steel wire in place. So now you can start with retraction. Usually I would remove the springs. As an alternative, you can of course leave the springs or use a steel ligature and wrap it around. Yeah. This is now during retraction, after retraction, and after removal of the lingual braces and the mini screws. As you probably know, we can remove the mini screws without a anesthesia. Before and after, again, without a herbs, which is not so comfortable for adults. And if you're using a herbs, you always have some protrusion of the lower incisors, and in some patients you don't want this. Yeah. Another interesting case, very difficult case. Class 2 patient of mine, she had a an open bite situation, open bite class 2. And she went to many orthodontists, I think at least 10. And I've been number 11 or 12 because all of the orthodontists recommended surgery because of the bimaxillary protrusion of the incisors, because of the open bite, etc., etc. You could not take out bicuspids because bicuspids were already extracted in the upper arch. So difficult case, difficult case, difficult patient. Yeah. So I recommend that if you don't want surgery, we can go for upper molar distalization. But because of the open bite, we have to change the mechanics a little bit. And if you change the angulation of this wire, you can get distalization and intrusion. So it's like an escalator in a department store. We are distalizing and at the same time we are intruding the teeth. So it looks like this on the model, and again intrusion during distalization. So this is how the mechanics is designed. And this is how it looks like in the mouse. Open springs. After 3 months you don't see much. After 6 months you see some spaces here and there. It's bodily treatment, bodily distalization, so it takes some time. We have to be patient. This is now start of retraction. Again, we didn't need so much distalization. We needed distalization and intrusion. So let's have a look at the cephalogram before and after. And you see very easily, without extraction, without a herbst, just by distalization of the upper molars and intrusion of the upper molars, and the open bite was fixed and the severe protrusion. So this is after or during retraction, and again before and after. So quite a nice results after removal of the mini screws and before and after profile. So funny thing, please have a look at the profile change. It looks like the profile has improved. Why has the profile improved? I think the answer is we have intruded the molars, and due to this molar intrusion, we see auto-rotation of the mandible. So this is very important. If you try to intrude molars, the auto-rotation of the mandible will always result, and this is of course good for class 2 patients, but it might be a problem for class 3 patients. So very important, we have to consider this. Another patient with an open bite, class 2. She was a dental student in our university. Now she's a dentist. And interestingly, she's now doing a postgrad program in orthodontics because she was so happy with the treatment. Again, open bites, class 2. We used the Bennett slider. With this angulation, goal is always in these cases distalization plus intrusion, and we change the wire for this. So this is with the Win appliance. We are mostly using Incognito and Win in our department. After distalization, and next step is now retraction. After retraction, and you see the change without a herbst, without up and down elastics. have always a high risk of um, root resorption if you use up and down elastics. And sometimes it looks like we have penetrated nasal cavity. So don't care about this. This is never an issue. Yeah, we never experienced any problems with this. Again, you see retrusion of the incisors due to distalization and intrusion of the molars. Before and after. Uh, before and after. So take home message out of these cases, use angulation of the guiding wire if you want to have an additional vertical control. Yeah. So most interesting combination is from my point of view the combination with aligners because aligners are nowadays very popular and many patients are asking for it. Yeah. This is our first patient where we started to combine aligners and the Bene slider. It's a class 2 patient, not enough space for the canines. So treatment goal was distalize the molars to get enough space for the canines. This is the Bene slider in place, and this is always the same story. Have a look at the canines. They're getting more space because the bicuspids are following the distalized molars. Now it's an easy case. Now you can put brackets on the buccal side, brackets on the lingual side, or finish the case with aligners. Yeah. Now it's an easy case for aligners. So I like this combination to modify a difficult case for aligners with using these sliders into an easy case for aligners because aligners are able to do now these easy things. Yeah. So again, distalization, scan, or take an impression and finish the case now with aligners. Again, this is how we started. We started with bands. Yeah. But Invisalign and some other companies had problems with the bands in place. So we changed the mechanics a little bit. So nowadays we are not using bands anymore. We are using bonded tubes. I will show you these bonded tubes in a couple of minutes. This is the finish of the case. As soon as the spaces are close to the distal, we can remove the slider. You see for the last finishing aligners, we don't need the slider anymore. This is after removal of the mini screws and a nice result. No need for class 2 elastics. Of course, you can treat this case also with class 2 elastics and aligners, but some patients are not so compliant. So this is a nice alternative for those patients who are not so super compliant. So this is how we design the mechanics nowadays. We are using these bonded tubes, and this is how we design the aligners. They are wrapping around this connection area. So this connection area is like a big attachment. So if you want the liner to cover this connection area, we first have to insert the Bene slider, then take a scan or take an impression, and then you will get the aligners. Okay, so this connection area is covered by the aligner. This is the best technique from my point of view. Here you see the steel ligature. If you want to modify your mechanics from an active distalization device into a passive molar anchorage device. Yeah? So let's have a look at some patients. An adult patient, class 2. We need round about maybe 3 or 4 millimeters of distalization. We have a severe overjet, severe protrusion of the upper incisors. So we have some cases where we have done Beneslider and aligners simultaneously. And on the other hand, we also have many cases where we first have distalized, then took an impression for aligners. So both is possible. Yeah, both has pros and cons. To be honest, nowadays I would always do first distalization just with the Beneslider. As soon as the molars are in a good position, fix the molars with this steel ligature and then take an impression or a scan for aligners. Because if you do it simultaneously, there's always the risk that the Beneslider and the aligners are not perfectly synchronized. Yeah? Because synchronization is maybe an issue because in clean check you have to make the same movements of the molars as the Beneslider is predicting. Yeah, so this is a little bit the disadvantage of using these appliances simultaneously. It sounds very smart, but this is a little bit sometimes a little bit tricky. So in this case, we did it simultaneously. So I'd like to show you this case. We have to synchronize Beneslider with aligners. It's possible, but we have to sometimes to look twice and think twice. So sometimes it's easier to do first Beneslider, take an impression, and afterwards finish the case. In this case, we did simultaneous distalization of the full upper dentition. As you can see right here, I like to show you the video again. So you don't need step-by-step distalization. All teeth are distalized simultaneously. This is possible because we have a slider in place. So this is a situation after a couple of months. You see we are coming more and more to a class 1. This is after 10 months. We have now in the molar area a nice class 1. Just close now small gaps, get after deep bite, and this is a situation at the end of the treatment. So simultaneous distalization and alignment. So it's possible, this is a take-home message, but you have to think about synchronization. Yeah? Another interesting patient, she asked for aligner treatment, but she was a very difficult patient because she had a severe midline deviation and she was very unhappy with this situation. Yeah, so the treatment objective was to distalize in the second quadrant. You could not take her out of bicuspid because she already underwent an orthodontic treatment. So this was not an option. So we for sure need distalization in the second quadrant. So in this case, again, simultaneous distalization and use of aligners. I think it's again easier probably first to distalize. Yeah, but in this case we did it simultaneously and not a full arch distalization, in this case sequential distalization. Yeah? So in this case first distalization of the second molar and after that retraction of 6, 5, 3 and the front teeth. Yeah? So these are the follow-ups. You see the steel ligature. Why we don't want to distalize more. As soon as the molars are in the perfect position, we want just to fix them. So using the steel ligature. So now the molars are now in the good position during the retraction. After retraction, mini implants were removed for the final finishing. And you see at the end we have a very nice midline correction, and patient is now very happy with the result. It's almost perfect. Yeah? After 1 year, still a very nice occlusion and a nice correction. Another patient with a midline uh, deviation and a asymmetric class 2. So we needed more distalization in the second quadrant, a little bit distalization in the first quadrant. She asked for a liner treatment. You see the situation in the second and third quadrant. Because she had a discrepancy of around about 6 to 7 millimeters, we did two things special in this situation. We used the Bennett slider on 2 mini implants plus class 2 elastics. So you can combine it. If you have so much distalization and you maybe want the mandible to come forward as well, you can combine class 2 elastics with the Bennett slider. But first we started with the Bennett slider. In this case, we added a bonded tube to the bicuspid. Why? We needed so much distalization, around about 5-6 millimeters. So these are the follow-ups. You see sequential distalization, what we usually do to have a better aligner fitting. This is now the situation where we combined it with aligners for the final treatment. As soon as the molars are in the perfect position, we are not activating the screw, the open spring anymore. This is now the situation where the molars are in a perfect position and the front teeth were just aligned at the end. Patient at the end of the treatment on the right side, you see a nice occlusion, and this was the situation before. Nice bodily distalization after removal of the mini implants. And if you want to see more about this, Ravinanda is going to publish this book next year, and we have the treatment approach of combining Bennett slider with aligners in this book. I think it will be published next year. You see again in the second and third quadrant, we had a lot of distalization and class 2 correction on the left side of the patient. So I want to keep this lecture very clinical, but I'd like to show you just one paper where we analyzed the effects of the Bennett slider, published 5 years ago by Dr. Nienkamper, and he found out that the failure rate of the mini implant is quite low, just 3.9%, so 1 out of 20 cases more or less. And the speed of distalization is 0.6 millimeters per month. This is especially important if you want to speak to your patient about the treatment speed, and second important point is if you want to synchronize distalization of the Bennett slider with aligners. You have to know the speed of the distalization, the average speed. It's of course an average because the first 2-3 months you don't see much, so probably the speed is a little bit lower, but afterwards the speed is catching up and becoming higher. So you saw now the slider. I like to show you now as an alternative the pendulum and screw distalization mechanics, because this is the topic of my lecture today, how we can use mini screws for distalization. Of course, there is not always just one appliance. We have more than one alternative. So this is how the pendulum appliance looks like on mini implants. It was published 2 years ago in the Australian journal. Uh, Many of these papers are, by the way, available for free download on our website, the website from our university. I will show you the website at the end of our presentation. Yeah, and you see one of the patients that we have treated with the pendulum, class 2 adult patient. He already was treated before with 2 bicuspid extractions, so to take out 2 more is of course not a good option. So we distalized. In this case, again, with a pendulum, just to test it, how it works. And to be honest, I'm not a super fan of a pendulum because it's always not so easy to activate it. We need anti-tipping, anti-rotation. It's a little bit tricky. So I like, to be honest, the slide a little bit more because it's easier to activate. Yeah? But this is the pendulum now in place. By the way, this wire is a flexible wire. We used the 1.1 millimeter for the slider, but this should be much more flexible. So this is a different wire. It is 0.8 millimeters because we need, of course, some flexibility if we are using the pendulum. This is after 4 months, so maybe this is an advantage of pendulum. The speed is a little bit higher. Why? No friction. But again, I'm not a super fan of pendulum mechanics because of the um, not so easy activation procedure. So molars are now almost in a class 1. I was lucky, bodily distalization, which is not uh, always the situation in pendulum mechanics. Yes, maybe it looks like we have penetrated nasal cavity. Don't care. Yeah, this was 9 millimeter. Maybe this is the reason why we switched now to different sizes. We are nowadays always using just 7 millimeter if we are using a posterior screw. Yeah, um, because again, it's not a risk if you penetrate the nasal cavity, but the patient has not a good feeling, some nose itching. So that's the reason why we switched to shorter mini implants posteriorly. So again, molar distalization is always a two-phase treatment. First, distalization. Second, front retraction. And maybe this is the second reason why pendulum mechanics are not the best appliances. How much should we activate them now for molar anchorage? If you don't activate them at all, the molars might move mesially. If you activate them a lot, you might get some more distalization. So it has to be a little activation, but nobody knows for sure how much. So this is maybe the second disadvantage of pendulum mechanics. We don't know how much we should activate them. Yeah. So, but Principle is the same procedure, similar procedure. Level as soon as you have a rigid stainless steel wire in place, and then retract all teeth simultaneously. This is now after retraction, and you see occlusion is getting much better. Yeah. So in total, the treatment was very fast. Yeah. 6 months of a pendulum for distalization, and then 6 months for leveling and retraction. Round about 3 months leveling and 3 months retraction, because we can retract all teeth simultaneously. No Herbst appliance, no class 2 elastics, just by distalization of upper teeth. Patient at the end of the treatment, maybe two black triangles are not so super nice, but patient was happy that we have been finished so fast. This is a young patient, and maybe this is a good patient for a pendulum, because in this patient we had the situation that the molar in the first quadrant was to be not distalized bodily, but the job was to upright it. And imagine you're using a slider for this purpose. It doesn't make sense because you don't want to bodily distalize this molar. You want to just upright it. Okay, so treatment goal was in this situation uprighting of the first molar, extraction of the deciduous molar. This is the second bicuspid, and this should be aligned afterwards. Okay, so far so good. This is the treatment plan. So pendulum in place. It's more or less just active in the first quadrant, and again, not for bodily movement, but for an uprighting movement. Okay. Um, so this is after around about 3 months. You see, uprighting can be very fast, not much bone that has to be remodeled. And now there was enough space for the dentist to remove the ankylosed and impacted milk molar. This is after extraction of the milk molar. And now there was enough space for the second bicuspid to erupt, and believe it or not, it moved to the occlusal plane by itself. Okay, so funny story. The tooth always wanted to go, and now was able because there was enough space. Yeah? So now it's an easy case to finish at the end, level and aligning with brackets, and this is the patient at the end of the treatment. So we spoke about the sliding mechanics, we spoke about the pendulum mechanics. There's additionally the option to use a screw mechanics. What does it mean? You can patient can activate a screw once a week for distalization. And for this purpose, I like to show you this young class 3 patient. We had a maxillary deficiency, width appraisal was minus 4.9. So we needed expansion. We needed maxillary protraction. And at the end, we also needed molar distalization. Yeah, so more or less three goals. Again, maxillary expansion, maxillary protraction, and molar distalization. But milk teeth were lost very early, so there is not much dental anchorage. So a poor dental anchorage situation for rapid maxillary expansion and class 3 treatment. Yeah? Not many teeth for anchorage of an RME and class 3 traction appliance. So we use the hybrid Hyrex. Maybe you know the hybrid Hyrex appliance. We are using it for rapid maxillary expansion and maxillary protraction, and the goal is to have no dental side effect. That means if you are using a face mask, the teeth are not moving mesially, only the maxilla can come forward and so get more skeletal effects and less dental side effects. This is called hybrid Hyrex. And I think in the fourth webinar, we speak about this procedure. Again, maxillary protraction without dental side effects. But in this case, we needed orthopedic maxillary anterior protraction, but orthodontic molar distal traction. So it sounds strange, it sounds very difficult, but it's not so difficult if you're using this hybrid Hyrex distalizer. So let's have a closer look at this appliance. We have an expansion screw, everybody knows, but additionally we have two distalization screws. And we have here hooks now for the face mask. Okay, so again, we are using the two mini implants to have a good anchorage for expansion in the first phase. Additionally, maxillary protraction, and in the third phase, molar distalization to get space for the canines, because this space is, of course, not sufficient for canines. So expansion, maxillary protraction, and molar distalization, we call this appliance hybrid Hyrex distalizer. And if you want to see more about this, from my point of view, very helpful appliance. It's also for free download on our website. So we started with RME and maxillary protraction. You can use a face mask. And for those patients who don't like a face mask, you can also use the titanium plates. We will speak about this later. Maxillary expansion, maxillary protraction, and now again the patient is activating these screws once a week, the mother or the father of the patient. Yeah? 1/4 turn each week, and this is now what happens after distalization. You see, now we have much more space for the canines. Yeah? So nice distalization. So interesting story. The whole maxilla came forward, but the molars were distalized. So very helpful appliances for these cases. So now you can relax and wait for the canines. Yeah, so very effective appliance, rapid maxillary expansion, maxillary protraction, and distalization. So in total, we came from here to there with just one appliance. Yeah, looks magic. Yeah. So now it's an easy case. It was a very difficult case before. Now it's an easy case. It's almost a class 2 case, and we have many of these cases. If the patients are wearing their face mask properly, you can do a lot. And now it looks like we have won the game. We have an overcorrection. Width change is 7 millimeters. Again, the hybrid Hyrex is very effective. And we have almost now, in this case, a class 2. So before it was a very difficult patient. Now it is a very easy patient. Again, many patients are asking for Invisalign treatment. So we finished the case now with aligners. Again, do the difficult things with the mini implant bone mechanics, and afterwards do the easy things with aligners. I think it's a very smart combination. Yeah. Before severe class 3, hybrid Hyrex distalizer in place, and now it's a nice class 2. Yeah, so overcorrection is very important because the mandible might grow in the next years. Width change 7 millimeters. Nice, improve of the profile. Very important, the patients have to wear the face mask. What is the best age for class 3 traction? Again, we speak about this in the fourth webinar, but the information is obvious from the research studies. Best age is around 8 to 10, maybe 11. Not all patients are wearing the face mask properly. We can measure the face mask wear time nowadays. If you're interested, we have published this 3 years ago. We used the electronic chip in the frontal bar of the face mask. We measured the wear time, and this young gentleman, he was wearing the face mask properly 10 hours, more than 10 hours per day, which is good. But we also had patients like her. Yeah, you see many days where she didn't wear the face mask at all. So for some of the patients, the face mask is not so super popular. So is there an intraoral alternative? Yes, there is. And this is what we learned a little bit from Hugo de Klerk from Belgium. But we think we have improved his approach a little bit. Hugo de Klerk is using 2 plates. We tried this, but had a high failure rate of the 2 plates. So we changed in the lower arch, and nowadays we are just using 1 plate. I'd like to show you this young class 3 patient, 11 years, a little bit late, but 11 is still okay. Again, best age would be 8 to 10. So severe crowding, severe class 3, severe maxillary deficiency. So we use the hybrid Hyrex distalizer, expansion, afterwards distalization. She didn't want to wear the face mask, so we used class 3 elastics to the mental plate. Okay, it's a little bit surgery if you're using these plates. Yeah, and to be honest, 2 times the surgery. First for um, putting them in, afterwards for removing them. Yeah. Again, now distalization. You see some spaces before and after class 3 treatment, which improved 6.2 millimeters. And this is now the patient at the end. And we can help many patients. We still have, of course, some patients that needed surgery later, but the group of the people that need surgery is much smaller. You see the nice improvement of the midface. If you use mini screws in the palate, you see less dental migration and more skeletal reaction. And this is more or less what we want. So you saw the screw mechanics for distalization, and we are using this screw mechanics especially in patients where we are using the face mask, because the screw mechanics is very rigid, because if you apply the face mask and spring, you might get some jiggling of the molars. So rule of thumb, if you use a face mask, so if you have a class 3 patient, we are using the screw mechanics. Of course, you can combine pendulum and screw mechanics. This is, for instance, the frog appliance from Forrester Dents, a young patient where we use this. You see molars are moving. You can reactivate this, so it's a little bit a combination of pendulum and screw mechanics. Enough space. Now leveling and aligning, retraction. This is a patient at the end. Just to show you that there is a possibility for combination. Another patient, adult class 3 patient. He wanted surgery to improve his profile. So skeletally, he's a severe class 3. Dentally, a mild class 3. So what does it mean? We need some decompensation before surgery. That means we have to distalize in the upper arch or extract in the upper arch. He asked for non-extraction, so we distalized again with a combination of a screw and a pendulum. Looks like this, you see. Again, you can do these pendulum mechanics. I don't like them too much. I would always use a slider, easier to activate, and in phase 2, if it comes to retraction of front teeth, much easier as an anchorage device. But I like to show you all different mechanics. And then again, in this case, we use this pendulum with screw mechanics. So decompensation and then surgery. This is the patient at the end of the treatment. So again, the overview, we have a slider, which is the standard in our department. We have the pendulum mechanics, and we are using the pendulum especially in those cases where we don't want to bodily distalize, but to upright. And the screw mechanics, and as mentioned before, we are using the screw mechanics, especially in those patients where we are combining with face mask therapy to avoid jiggling of the molars, that you don't push the molars distally with a spring and mesialize them again with a face mask. If you have a rigid screw mechanics, this don't happen. So now I have a couple of minutes left, and I like to show you a short overview how digital technology has improved these mechanics. All mechanics that you have seen in the last 1.5 hours were bent by technician, and nowadays digital technology can help us a lot, not just to CAD/CAM design the mechanics, but also to find the best insertion site for the mini implant. If you're software hero, you can use freewares, for instance, this Blender software, to find a perfect position for your mini implant. TEDmatch is another opportunity from OnyxSef. If you are not a software superhero, you can give it to somebody else. This is what I recommend. There are a couple of companies nowadays offering these insertion guides. So I think insertion in the palate is very easy, but if you want to start and you don't feel so comfortable where to insert the mini screws, maybe these guides can help you. Second advantage of these guides, you can insert mini screws and the appliance in just one appointment. Because the appliance can be pre-fabricated. Why? The technician already knows where you are going to insert the mini implants. So very nice technique, very smart technique from my point of view. So I'd like to show you now some cases. This is, for instance, a patient where I wanted to distalize, and I used this insertion guide to facilitate that I can insert the screws and the band slider in just one single appointment. Paper is published in July in the AGO. This was one of the first patients where I used this. Again, you get a proposal from the technicians, and like Invisalign, you get a check, like a clean check from Invisalign, and if you approve it, the guide and the appliance will be manufactured. And then you choose just one appliance, one appointment where you can use this guide. And it makes it very, very easy. Insertion site, insertion angulation, and even insertion depth are predetermined. Okay, so it makes it very easy for you. All you have to do is do anesthesia before and then insert the 2 mini implants with this guide. And it looks like this. It takes maybe 5 to 10 minutes. And again, in the same appointment, you can fix the slider or the expander on the 2 mini implants. This is the advantage. You have a very good positioning of the mini screws because you can do this in advance with a cephalogram or with a cone beam CT. Both is possible. So this is the patient before and after. You see a nice distalization, so the patient doesn't have to do much, just clean the mini implants. Now it's a case that can be finished with buccal braces, lingual braces, or even aligners. This case was finished with buccal braces. Nice bodily distalization, but braces just for, I think, around about 5 or 6 months, not years. So the time when you need braces is shortened very much. We started a university spin-off, and it's called TEDman. And our idea was to offer this insertion guide as well. I'd like to show you this video where you can see the insertion. Sorry. Make a little bit forward. You see injection. So you make two small shots, one left and one right. So not a big thing. This is our newly designed insertion guide. And then the insertion starts. Just count from 10 to 0, and then the patient knows it's done in a couple of seconds. So name of this company is TEDman. I will show you the address afterwards. And just send us your STL file of the upper arch, and you will get this insertion guide and the appliance, both. So I think very comfortable. Okay, so all you have to do, just count from 10 to 0. You see, it depends on the speed. You're done after 10 seconds. You see how deep we have inserted, and then stop. It's not a big thing for the patient. It makes insertion very, very easy. Was it painful? No. This is the answer. Okay. So maybe we see the second insertion. Okay. So quite a fast forward and easy and secure procedure. If you don't think you can find it in the mouth by yourself. Okay, guided mini implant insertion. I think this is the future. We have banned the mechanics, as we have talked about nowadays. We are not bending it anymore. Can you? I think you can, if you want to, still bend it chair side internally or the plaster model. But of course, the future is digitally, and this is what we are doing nowadays. We are CAD/CAM designing these appliances. For instance, the hybrid Hyrax expander. And so we take a scan or take a silicon impression, send it to us, and we are going to plan the mechanics and the insertion guide. And you can, of course, only sky is the limit if you want to design the mechanics. And this is the advantage of CAD/CAM design. You can design every possible mechanics, and this is afterwards um, 3D printed using selective laser melting procedures. Yeah? Um, Scanners have sometimes a problem with the metal surfaces, depends on the scanner, so you can use these scan bodies, but this depends on the scanner. If you have a 3-shape scanner, you don't need these scan bodies. Again, um, after scanning, we are designing the mechanics. This is, for instance, a hybrid Hyrax expander using 2 mini implants in the best insertion site, not Swan Moon. He is using the posteriors, but there's no bone. Have a look at the cone beam CTs. There is good bone availability only in the anterior palate. This is how it looks like. In this case, for instance, in combination with lingual appliances. So 10 years before, we expanded, waited for 6 months, and then we continued the treatment with lingual. Nowadays, you can do it um, together. So I'd like to show you one case where I use this distalizer with screw mechanics, and this is CAD/CAM made. It looks like this before and after distalization. In this case using brackets, and this is the situation after debonding. So the sky is only the limit if it comes to designing of these kind of mechanics. Of course, you can also design sliders, and this is how it looks like. Yeah, this is how the sliders looks like fixed afterwards on the mini implants. CAD/CAM made Bene slider. Again, we can also change the angulation if we want to distalize and intrude or extrude. So there are digitally, of course, many possibilities. And this is what we are offering nowadays, combination of insertion guides and these CAD/CAM appliances. So if you want to see more, you can go to the Tadman website and you will find much information about these CAD/CAM made appliances. So this is what you get if you want to try this. How we can insert now this CAD/CAM Bene slider. I will fast forward. This is how it looks like. You fixed it on the 2 mini implants. Again, we are nowadays more or less using paramedia mini implants, and because there's a high precision, you mostly can fix it directly. This is the small fixing screw that is used for fixation of the sliders on top of the mini implants. Okay, this is more or less mostly using manually. So this is the procedure. And again, you can insert mini implants and the appliance in just one appointment. Now, we always have done this in 2 appointments, which is okay also, but you have to take an impression, etc., etc. This is a small fix. Sometimes takes a little bit, but then it's fixed at the end. Yeah, okay. So jump a little bit forward. Now both are fixed. Then you fix the rest of the appliance. In this case, it is bonded. Finally, the appliance is activated. Then the patient is rescheduled in 6 weeks. Was it painful? Not painful, not a big issue. This is the patient at the end. Okay, so if you want to learn more about palatal tats, today I talked 2 hours about just distalization, but we can also mesialize, intrude molars, expand, mesialize and distalize, etc., etc. We can combine it with aligners. I recommend this website, and this is the University of Düsseldorf orthodontic department, and you will find many papers. So take a picture of this QR code, and you will find this website. In Russia, you can ask for the benefit mini implants. If you go to this website, there's a nice doctor helping you, Dr. Jana. Next week, we will speak about mesialization, and we can close spaces without brackets. This is, for instance, the case with missing first molars. This was published in the May issue of the AJO. And big advantage is that you don't need much compliance for mesialization. Nowadays, we are using this B-mesial slider with bonded tubes. And the smart thing, we can close spaces, so do the difficult things with bodily movements and finish the case with aligners. So next week you will see many of these cases. We can distalize on one side, mesialize on the other side. We call this mesial distal slider. Okay, this paper is also available on our website. So this is my last case for today, a funny case where we distalized on one side and mesialized on the other side. Why? The midline was off, 2 millimeters. Again, it's a funny case. Why is this a funny case? The patient didn't show up for 6 months. So please imagine what happens if you want to check the midline. To fix the midline, again, we distalized in the first quadrant, mesialized in the second, just to correct the midline. But she didn't come for 6 months. So funny story. Wow. Yeah, I think it's very impressive that you can use these palatal screws to rotate all teeth on the maxilla. Okay, so for us, this was a funny case. Why? We know how to fix it. Okay, so we changed sides. The side that was mesialization side became a distalization side, and vice versa. Okay, so this is without control of 6 months. So very important. These appliances are very effective, so we have to control them. Yeah, so we changed sides again. Distalization side became mesialization side, mesialization side became distalization side. So at the end, it was everything perfect, and the patient was happy because the midline was at the end in the midline, in the middle of the face. We will speak about rapid palatal expansion using 2 or 4 TADs. We will speak about, I think this is the last webinar, combination with aligners. I think this is very smart. We talked about class 3 treatment, molar intrusion. I think this is also one of the webinars for molar intrusion, molar uprighting. And again, if you want to see more, you can see the next webinars and or visit us in Düsseldorf at the university. Once in a year, we have a very nice meeting, and I like to invite you for next year in June. The benefit user meeting, and this takes place at the 5th and 6th of June. Next year, we have Marco Rosa visiting us. He's one of the superheroes worldwide if it comes to space closure in the upper arch, and he is using the mesial slider, and he has super finished cases with missing laterals. We have scheduled our benefit user meeting 5th, 6th of June, and the idea is that attendees from all over the world can visit the EOS meeting in Hamburg afterwards. So you can directly take a train. It's 3 hours from Düsseldorf to Hamburg. It's an ICE high-speed train, and you can come to both meetings. So I like to warmly invite you to both of these meetings. So just a couple of minutes left. I'd like to come to the take-home messages of my lecture. I think it's crystal clear that the anterior palate is the best insertion site in our university. We are not using buccal mini screws in the upper arch anymore. We moved totally to the anterior palate. Since we find a very low failure rate, almost no risk of root damage, biggest advantage, we can move the teeth as we want. So the mini implants are not in the path of the moving teeth, and we can combine it with invisible mechanics like aligners. I think this is the future for the orthodontic profession. We can distalize without brackets. We can get a vertical control, and today I spoke about especially distalization. We saw the slider, we saw the pendulum, and the screw distalization mechanics, and we talked about the different indications and combinations. So again, if you want to get in contact with me, you can send me an email or contact me on Instagram, Facebook, or YouTube. This is again the QR code of our website. And again, you find many articles for